So good afternoon. Thank you so much for taking the time to see us today. My name is Dr. Emmanuel Gurosby. I'm an interventional endoscopist and currently medical director for Castle Biosciences. Today, I'm actually joined by my esteemed colleagues who are experts in their own field of foregut surgery, interventional endoscopy, and gastroenterology. So I'll let them introduce themselves.
Hi, I'm Dr. Dan Lister from Heber Springs, Arkansas, foregut surgeon, the president-elect of the American Foregut Society, and excited to be here.
Hey everyone, that's Farhan Quader. I'm one of the interventional GIs over at North Shore Hospital in Evanston, Illinois. Did my training down at WashU, decided to move up to Chicago. I deal a lot with foregut diseases, including Barrett's esophagus, and that's how I kind of got involved with Castle Biosciences. Glad to be here.
Hi everyone, I'm Sarah Enslin. I'm a physician assistant at the University of Rochester Medical Center in Rochester, New York. I'm an APP manager for the Department of Medicine and the co-lead APP for gastroenterology, and have a special interest in GI oncology. Happy to be here today.
Today, we'll discuss about the challenges in managing Barrett's esophagus, the use of TissueCypher tests, and actually trying to use this test in a multidisciplinary manner. So I'd like to ask my colleagues back, what are the unmet needs for Barrett's esophagus that you encounter in your current practices? Dr. Lister?
So when I have a patient that's newly diagnosed with Barrett's, they came in, they've seen their pathology on my chart, and they've already Googled Barrett's, and they're scared. So they come into the office, and the scenario I'd explain to them is, imagine a field. On this side of the field, normal esophagus, reflux esophagitis, non-dysplastic Barrett's, fence. On the other side of the fence, low-grade dysplasia, high-grade dysplasia, and then a cliff called esophageal cancer. And I tell them, as long as they're on the left side of the fence, they're safe. My job as their physician is to walk the fence. And before TissueCypher, the problem that we had was that endoscopy biopsy is a static picture of a dynamic situation. There's movement there, but unfortunately, you don't know what speed that patient is moving until you get the second picture at the second set of biopsies at the next endoscopy. And hopefully that patient hasn't fallen off the cliff by then. TissueCypher allows us to have almost like a video. So we know what patients are running for that fence that are at high risk, and we can intervene early, or the people that are low risk that are not going to get near the fence. So that's why I love this technology.
And I like your analogy of the fence. You've nicely, pun intended, corralled the topic very well. So, dysplasia is yesterday's news. So we have to go beyond dysplasia sometimes to address this topic. So, Dr. Quader?
I would echo what Dr. Lister shared. So as an interventional GI, I get a lot of referrals for Barrett's, including non-dysplastic. And patients see all of these reports on their MyChart. They go start Googling dysplasia, and they think that they're going to get cancer, and they want to rush in to see me. My wait times are several months out, but they want to come in the next week because they think they're going to get cancer if we don't do something about this. My personal bias is that our current guidelines, although they're good, I think they're not too personalized, and there's certain populations that progress faster than others. For example, the other day I just had a patient with non-dysplastic Barrett's esophagus with a family history of esophageal cancer. And the guy came to see me because his GI told him to come back in 3 years. Generally that's a recommendation that we have, come back in 3 to 5 years, depending on how much of a Barrett's segment you have. But the guy was concerned that he's going to develop esophageal cancer and wanted to see me for an ablation. So, that's kind of where I utilize this testing, because there's these kind of unmet needs, and our guidelines don't completely fulfill all of these kind of different scenarios. The other thing is that it helps us prognosticate. It helps us kind of determine when to bring these patients back. We've all seen that one patient or a couple patients that progress within their interval endoscopy period. And how do we capture those patients? Just a couple months ago, I did a young man actually with esophageal cancer, had an endoscopy about a year ago with essentially non-dysplastic Barrett's. It was like a C2M5 lesion, non-dysplastic. Now comes in a year later with dysphagia. We're thinking, all right, it's probably an esophageal stricture from just reflux. Go in, it's clearly got T3 disease, cancer. So there's clearly these patients that are being missed on endoscopy, and we need to have a better way of stratifying and kind of figuring out how to manage these patients. But also there's a huge patient anxiety component, right? So like Dr. Lister was saying, you get this Barrett's and your patients have no idea what their risk of progression is. And you tell them, hey, look, you have a possibly 3 to 5% risk of progression in 3 years, and they're like, wait, what? I'm going to get cancer. There's a 5% risk of getting cancer. So this test kind of helps me determine or kind of give them numbers, put numbers in front of them to tell them that, hey, look, you have this percentage risk of becoming cancerous, et cetera. So I think those are the unmet needs that I've encountered in my practice.
So I agree with you, Dr. Quader. If you guys look at the current publication, the American GI Association, it just published a couple of days ago, the current guidelines for Barrett's endotherapy. It does recognize the fact that there's a segment of non-dysplastic Barrett's that could benefit from ablation, and it does cite or recognize TissueCypher, a tissue systems pathology 9, as one of the means to re-stratify these patients. Sarah?
Yeah, I think those are all great points that have been brought up already. I think in addition to that, it's the patient education from the beginning. They come in for Barrett's screening or Barrett's surveillance, and they don't necessarily know what it is. They know we're looking for precancerous cells, but they don't know what that means or how that translates to things. And it's to be able to have some additional speaking points, and you can give numbers, but patients don't always understand that. And everybody's perception is a little bit different. A number to one person may be something that's absolutely terrifying and cause a lot of anxiety, or somebody else may take that and translate it into, well, that's reassuring, and maybe I don't need to do my surveillance. So I think that that's the other unmet need, is how can we provide the information to patients in ways that they can understand it? How do we translate that into a conversation with them? How do we sit down and develop that trust with them? And then what are the additional tools and prognostication, including TissueCypher, that we can use to then make our recommendations and really be able to sit down with the patient and explain that?
I couldn't agree any more better than that, because in my own practice, for example, TissueCypher provides for me not just a risk class, but an actual number. I could have a conversation with the patient and their family members, or even the referred physicians that send patients to me in regards to the risk of the patient and what could be offered to them. So just a brief background for us about TissueCypher. We all know about our clinical workflow. We diagnose Barrett's esophagus during endoscopy. We obtain biopsies, and we look for either they're non-dysplastic, low-grade, or high-grade. And in here, we could use TissueCypher for non-dysplastic and low-grade or indefinite for dysplasia to further re-stratify them. We're not anymore, we're going beyond, by the way, from just population-based risk to actual personalized precision medicine to tell who's going to be high risk for progression or low risk for progression for high-grade dysplasia or esophageal cancer. Now, in risk stratifying these patients, TissueCypher uses these 9 biomarkers all pulled together in the assistance of AI, in addition to using spatialomics, which is cellular and histologic structure, to determine the risk for progression long before the onset of actual dysplasia that our pathologists can pick up. This is all set up in an AI system to provide a risk classification, as you see there, low risk and high risk. But something that's more important for me is that I could have a 5-year probability of progression, an actual number I could bring up in a discussion between me, the patient, or even the referring physician for that matter. Now, the nice thing about TissueCypher is that there's 13 peer-reviewed, validated studies. Half of these are all independent. This is one particular study led by the Mayo Clinic showing that a high-risk TissueCypher score is 7.8 times more likely to progress than a low-risk patient. In addition to being backed by 13 studies, all of these were built upon one of the largest data sets of Barrett's esophagus patients who actually have progressors. Because of that, Medicare has designated TissueCypher as an advanced diagnostic laboratory test. For us in the diagnostic world, this is an honor because there's only in thousands and thousands of laboratory-developed tests, there's only 15 of this that are out there. When it's an ADLT test, such as this case in TissueCypher, it means that's the only test and no other combination of tests can provide these results to you. One advantage is that I don't have to ask for prior authorization for Medicare when actually requesting this test for my patients. Now, these are actual case studies. We're going to have some discussion here. Both cases were actually submitted by our colleagues in the community using TissueCypher. So let's go to these two cases. These are two patients considered low risk of progression by traditional risk factors. Patient A is a 62-year-old white female, BMI is 29, non-smoker, some comorbidities. Patient B, on the other hand, is 71-year-old, a little bit older, white female, BMI is 29, non-smoker, and some other comorbidities. Aside from a father with kidney cancer, there's nothing that jumps out of here. Sarah, would you agree when you see this patient in your clinic that you'll agree that both of them are low risk?
Yeah, nothing in particular really stands out there. There's no red flags in either one of them. They're both white females. Neither one has morbid obesity. I would agree with that.
Any other comments, Dr. Quader, Dr. Lister?
You know, I'm always, I agree. There's not a lot of high-risk features here, but whenever I see any female with Barrett's esophagus, something sets off some alarms just because when we think about Barrett's esophagus, it's more of a male-predominated disease. And when I see Barrett's in a female, I get a little bit more concerned.
Yeah, I agree with you. Sometimes when I see husband and wife come to my clinic, the wife drives the husband. Sometimes I always wonder, not just the husband, but also the wife as well, if I could bring them to endoscopy, because traditionally we just relegated as the husband, the male patient, to be at a higher risk.
I would agree, and there's really no high-risk features here that would be red flags.
Now, when we do endoscopy in these two patients, or when they did endoscopy, because these are actual cases from our colleagues in the community, patient A has a prior classification of Z0M2, no hiatal hernia, no prior Barrett's esophagus. She did have some chronic reflux and some erosive esophagitis, LA grade C, and the biopsy was non-dysplastic, luckily. In similar fashion, when you look at patient B, she only had an irregular Z-line, no hiatal hernia, mild esophagitis, and chronic reflux, currently managed on an H2 blocker. The pathology was also somewhat reassuring initially as non-dysplastic. So any comments on these features?
Yeah, so for patient A, I don't love the fact that she's got erosive esophagitis despite being on twice daily PPI. I think in my mind that makes her a little bit higher risk. Patient B is on an H2 blocker with only mild esophagitis, so a little bit lower risk in my mind from that standpoint. Definitely would want to optimize medical therapy.
How would you manage these patients based on this current data that you have at hand?
Just to kind of, summarize also. So patient A obviously raises more alarms for me because she has this chronic reflux or grade C esophagitis, presumably on compliance with her BID PPI therapy. She also has a larger Barrett segment compared to patient B, which only has an irregular Z-line. And these patients that, I'm always a little bit concerned in these patients that don't respond to PPI therapy and why that is. So, in management-wise, can we switch around the PPI therapy here? Are they on pantoprazole? Can we go to omeprazole or esomeprazole? Or should we consider some sort of surgical evaluation of these patients?
Dr. Lister?
I would agree. The patient A is obviously progressing more than patient B. They've developed a hiatal hernia in this time period. They've got LAC, esophagitis on BID PPI. You have to make sure the patient's taking it correctly timing-wise, but that patient worries me more than B. B, with the current guidelines, you'd probably say come back in 5 years.
Okay.
In fact, with our current guidelines, the regular Z-lines, you don't even biopsy, right? So
I agree.
So that's a little bit challenging.
The thing with TissueCypher, it can allow you to decipher that things that meets more what you see in clinical or endoscopic findings. So let's go now to the actual TissueCypher results. So, Sarah, how would you interpret patient A?
So patient A is low risk according to TissueCypher, despite having those risk factors. Based on that, I'm a little bit more reassured when we talk about when should we bring them back for endoscopy for surveillance biopsies, but still would want to optimize them medically and make sure that we're controlling that esophagitis.
And you could reassure them when patients ask me, doctor, what's my risk for progression? It's less than 1% for patient A. So that would hopefully relieve their anxiety after looking at Dr. Google, for example, right? But Dr. Quader, what do you see at patient B?
So patient B scares me a little bit. This lady has a kind of indeterminate score, So you typically, when I present these scores to patients, I usually don't tell them what if they're low risk, high risk, or indeterminate. But I'll tell them that it's like you have a 9% probability of progression in 5 years. So, that's almost 10%. So 90% that you may not progress, but there's a 10% probability that you'll progress to some sort of higher grade lesion. And these patients I usually bring back sooner or will consider some sort of ablation. If I were to see this patient, I'd probably say, hey, look, patient B, I think we got to bring you back and do another endoscopy, make sure no other lesions are being missed, and let's take some more biopsies from all over the segment.
And then I'll just review back our slides for those that just came in. We're looking at both patient A and B, but just to review, endoscopically, when you look at patient A and B based on their features, you would have put your bet on patient A to be more at risk, right? So this is the value of looking beyond our clinical and pathologic findings and using TissueCypher to actually have an objective measure to risk stratify patients.
Yes, I would, patient B obviously is one that would have fallen through the cracks by our current guidelines. And TissueCypher, that patient in my practice would either be rescoped in a year or offered ablation, because with an ultra short segment of Barrett's, that's a very easy segment to treat endoscopically.
And I would have made the same decision as you guys have had, just based on clinical and pathologic features. So this is where TissueCypher helps me, even as an interventional endoscopist, when I see someone who's being presented to me as low-grade dysplasia, and I'm not really sure how to manage that patient when they have medical comorbidities. TissueCypher allows me to know the real risk of this patient that can guide the discussion between me and the patient and the referring physician as well.
Just to add a little bit more to that point, if I were to see the score of 9%, I would essentially treat, even though the pathology shows non-dysplastic BE, I would probably end up treating this patient almost like a low-grade dysplasia. The cancer risk of progression, low-grade dysplasia is about 8.5%. So this is kind of similar. So I'd say, hey, come back in 6 months. Let's do
And you're correct, because this will be in line with the new guidelines that came out a few days ago, showing that not all non-dysplastics are the same, and there's a subset of patients for which we could offer them precision medicine testing, such as TissueCypher, to stratify them properly.
I think the other thing that's helpful about this is that if patient B opts not to proceed with ablation, then we do get better adherence to surveillance, because you can have those conversations. You have to shorten the interval, but in addition to that, you now have a little bit more to tell them about why do we need to do this and why is this so important for you in order to detect any early changes.
I agree. I mean, I just saw a patient yesterday in clinic that had an endoscopy 10 years ago that had C2 on 5 Barrett's and decided never to show up again until yesterday in clinic when he decided that he wanted to get another repeat endoscopy. Having this kind of a score would actually, I think, improve adherence to endoscopy.
So for me, in my practice, TissueCypher provides another data point that I could use as another information I could present to the patient and why we make these shared decisions and what's the rationale behind them. So we now go to our second case of a low-grade dysplasia. Again, this is an actual case sent by our colleagues who's actually practicing out there in the community. And when you just look at the same risk factors, you get a 75-year-old gentleman. The medical history is no family history of GI malignancies. As usual, we find this often: obesity, chronic GERD, on the daily PPI, smoker. And on reviewing his medical records, you'll see that he just had EGDs in 2016 and 2019, showing a stable 3-centimeter non-dysplastic Barrett's. Other medical comorbidities include hypertension, hyperlipidemia, and diverticulitis. Any comments on these clinical features, Sarah?
Yeah, so had we not known this patient had Barrett's, this is the perfect patient to screen. He presents as a white male, doesn't have obesity, but does have that long history of GERD, as well as being a smoker. So automatically, I'm thinking that he's a little bit higher risk. Reassured that he's had non-dysplastic Barrett's on 2 endoscopies, but it is a 3-centimeter segment, and we know that there's progression over time. And so certainly he needs to be back in for repeat biopsies at this time.
I agree with that. This is like the prototypical patient that you would expect to have some sort of reflux or some sort of GERD or some sort of Barrett's, right? It's a white male in their 70s. He's a smoker. He's got chronic reflux. these are the patients that you're looking for to bring in for an endoscopy for evaluation of Barrett's. Given the fact that he had 2 non-dysplastic endoscopies in the past, and 3 years apart, I would say, hey, let's come in and let's do another repeat endoscopy.
I agree. The fact that he's had non-dysplastic Barrett's now for almost 10 years, his risk of that progressing would warrant another endoscopy. And he's fairly high risk with being a smoker or previous smoker and his age.
Okay, we'll move forward to the endoscopic findings. And this is a snapshot of the GE junction. You see that patient had a Barrett segment length of Prague classification of C0M3, no hiatal hernia, but the biopsy showed low-grade dysplasia, kind of different from the last one when they had non-dysplastic on the 2 prior endoscopies. Any comments on this finding, and how would you manage the patient?
Yeah, so current guidelines recommend that we can offer ablation. Surveillance is also reasonable. As we just discussed, he does have some other risk factors that make us a little bit more concerned. This is really where I rely on that relationship with the patient and hopefully the trust that we've built or that we are building together to be able to have those conversations and really invoke that shared patient decision making. But I think education is so important. And again, what information do we have that we can give them, what data points, and what speaks to them? Because every patient is going to hear something a little bit differently or understand something differently. And so how can we present it in a way that they'll understand? I often use the ladder analogy. And so we start, you just have GERD, then you can have Barrett's esophagus, low-grade dysplasia, high-grade dysplasia, and cancer. High-grade dysplasia is just one step below cancer. We really don't want to have you climb that ladder. This is one of those ladders. It's not the corporate ladder. We want you down low. And so that sometimes helps them to kind of conceptualize what we're talking about and why it's so important that we're looking for these things. And when we talk about treatment, I think it's important to give them some information about what to expect. And so I go through a lot of this is what the procedure looks like. This is what you would expect afterwards. And do I expect that you're going to come back post-ablation? Of course. And this is the time frame. And I kind of tease them a little bit and tell them we're going to be close friends. This is a long-term relationship. And so this is what we're going to do next.
Whenever I see these low-grade dysplasias, so in my practice, I get a lot of these referrals for low-grade dysplasia. And I guess it depends on who did the endoscopy and how long they spent looking at the Barrett segment. So typically what I would do is according to guidelines, I would bring this patient back in like the next 6 months or so, and I would rescope them. I would take some more biopsies and see if there's any other areas that are concerning. I would take 1 centimeter biopsies across the whole segment, trying to figure out what to do here. Typically, currently, prior to tissue cipher, I would essentially follow these patients every 6 months. The issue I always run into is that, well, let's say if I biopsy it in 6 months and it comes back a non-dysplastic, am I just going to tell the patient to come back at 3 years? It seems a little bit odd that I had low-grade dysplasia and then a prior endoscopy, and all of a sudden I have non-dysplastic, and I'm telling them to come back at 3 years. So the question in my mind is always that, well, am I missing something here? There's always sampling bias. Even on my best days, I'm probably sampling only 5 to 10% of the esophagus. So, am I missing here? That would be one of my questions.
Would you send this patient for a second opinion to another GI pathologist if you had one? Or in your practice, you already have one that's already adjudicated this case?
Yeah, so good question. So typically, my practice has supposedly a expert GI pathologist. So we typically will have the pathology slides reviewed, and then depending on what that shows, I'll usually send it out to one of the larger tertiary care centers also to have that reviewed. Just because having a low-grade dysplasia versus non-dysplastic really changes the outcome of what we're doing. If they have persistent low-grade dysplasia, the argument can be made that, well, maybe we should do an ablation. But if this gets downgraded to non-dysplastic, then we could say, hey, you're on a shorter leash. That also becomes an issue, though, because now if one pathologist has called someone low-grade dysplasia, and you send it off to a tertiary care center with an expert GI pathologist who says non-dysplastic, patients are always a little bit concerned that, well, why did this pathologist call it low-grade dysplasia, and why did this pathologist call it non-dysplastic? And you're telling me to come back at 3 years? That doesn't make sense. So, that always becomes an issue. So that's how I've also incorporated this test in my practice, where I'll say, hey, look, we have the score of this on this segment, and that's how we can kind of justify our endoscopy intervals.
Precisely, and even for me who does not have an expert GI pathologist, I've seen my pathologists rely more on a second data point such as tissue cipher to help validate what he's seeing. or what he knows that he cannot see, because we all understand that pathologists have limitations. There's so much inter-rater variability in the diagnosis of low-grade dysplasia.
I'm in a rural area where I don't have an expert GI pathologist, and I have, in the past, would have sent this out for confirmation for an expert second opinion. Now I'm using TissueCypher because I'm finding that the reliability of the TissueCypher is better than that second opinion, because if it comes back non-dysplastic on the second opinion, which pathologist was wrong? And you would hope that the expert GI pathologist wouldn't have been wrong, but they could. And with the TissueCypher score, I can use that as my confirmation that this is something that I need to go ahead and treat or something that I can watch.
I agree. In our medical professions, in our medical fields and societies, we always rely on these expert GI pathologists. From a medical standpoint, it makes sense. But from a patient perspective, it doesn't make sense. It's you tell them that at one point you have low-grade dysplasia, but oh wait, I got a review by an expert who says it's non-dysplastic. There's always a little bit of suspicion when it comes to that. There's always a little bit of doubt.
Yeah, so part of being successful in providing precision medicine that's personalized is having something that's objective, a number that you could actually tell a patient. If I ever talk to a patient and my risk class for them keeps on changing, they won't be able to feel that confidence that I have the right management set up for them. So having an objective precision medicine test like TissueCypher would actually help me risk align properly my management for that patient. So in the traditional management, we would profile this patient as high risk. We would recommend perhaps RFA, radiofrequency ablation, but this is the TissueCypher result.
Yeah, so this is actually really helpful. So, before we were able to implement this, the conversation's open-ended. Once we have this information, though, we can then take it back to them. One of the questions, and I'm sure we've all heard it, but it's always, well, if it was your family member, what would you tell them to do? And my response is always, well, you don't know if I like my family member or not. So let's use what we have that's objective in front of us. And so I think that being able to present this information to them now does give us a little bit more I think reassurance. It helps to reduce their anxiety, and it still speaks to that compliance. And so they are going to still be more motivated to do those surveillance endoscopies versus somebody who maybe doesn't have that. But I think that it gives us another speaking point for them.
I agree with that. What I normally say is that these are all pieces in a puzzle. And we're using all these small pieces to figure out what I should do for you specifically and not for someone else. What I generally say is that this test is awesome. The data behind it is awesome. But again, it's just one point and one kind of piece in this entire puzzle that we're going to solve. So in these patients, I say, hey, look, in this test, you came back as a 0.8% risk for progression in 5 years, which I think is pretty low. And I tell them that, hey, look, if I was a betting man, if I went to Vegas, and if someone told me, hey, your risk of winning or losing is 0.8%, am I going to make that bet or not? So this, again, is kind of a point that I use to educate patients, and I'll have a discussion with them. I'll say, look, you had low-grade dysplasia. I'm still going to treat you as someone who has a low-grade dysplasia, but instead of doing 6 months because of this testing, why don't we do it in 1 year? And I think we'll be okay. So once you present all this data to them and you allow them to be involved in the decision-making rather than the decision being made for them, I think they're more compliant and there's more satisfaction.
I agree. With a low-risk score like this, then you can let the patient decide, and they're well-educated in that they know that they have a low risk. That 0.8% may be more than they want to tolerate, and then we would proceed to ablation. But in a 71-year-old, most of the time they're going to say, "Now, doc, I'm fine. Let's just watch it." And this can reassure not only the patient, but reassure me that we're doing the right thing. And it also helps me pick the surveillance interval that I'm going to use.
True, and that also helps in terms of me communicating to my referring physicians. I'm sure some of you are in a tertiary medical center as an interventional endoscopist like Dr. Quader. We get a lot of referrals, and this would allow us to help explain to our referring physician why we had this shared decision with the patient and what was the basis for it, and not just a clinical or pathologic diagnosis. In summary, TissueCypher is actually a prognostic test. It's proven, precise, and personalized. It's the first test in precision medicine application in GI, prognosticating the risk for esophageal cancer progression. It has independent analysis that's been confirmed. It's the strongest risk factor, strongest predictor of progression to esophageal cancer. The results are actionable, and they're actually meant for individualized discussion of patient risks. TissueCypher is committed to our patients. This is how easy it is to order TissueCypher. So I'm going to ask you, in your practice, how do you order TissueCypher? How do you incorporate them, and what's your feedback?
Yeah, so in my practice, so we had, so initially when we started using TissueCypher, we had a little bit of a hiccup where there was some degree of autofluorescence going on with the assay. But if that happens to your practice, there's actually a very quick and easy way to get around that, and Castle will work with the pathology lab and try to figure that out. So in my practice, I've streamlined it. So if I get a Barrett's esophagus, if I do an endoscopy on a patient, if the pathologist calls it Barrett's esophagus, I'll message my staff and my nurses, and I'll say, hey, can we send off TissueCypher on this patient? I have a lot of these forms kind of sitting in my office, and my nurses will fill it out. It's very quick and easy for them. It takes them no more than a couple minutes to do, and then they'll send it off to Castle, and then Castle will take care of the rest. I do tell my patients that I'm going to send this test off, just because I like to keep them in the loop and have that as a discussion point later on when this test comes back. And I'll say that I'm sending this test off, and we'll see what the results on that show. And most patients actually all patients have been totally fine with sending it off. In fact, they're actually surprised that we have a test that can tell them the risk of progression. And I'll get the results in a couple weeks, and I'll have a discussion with them after that. I usually set up a clinic visit, just have a discussion with them. So everything's very streamlined with Castle. I've had no issues at all.
And to be clear, as we presented in the previous slide, this does not require for me to do an extra biopsy. It's using the same biopsies I obtained for part of my surveillance for Barrett's esophagus. I don't need to brush or do other special maneuvers to do this. In fact, if I would see a patient like I wanted to have a TissueCypher test, someone I probably did endoscopy 6 months ago, certainly the pathology lab can facilitate sending the slides or the tissue block for further analysis.
One of the things that my rep and I work very closely with is sending it off on referral patients. So for example, if another patient had an endoscopy done at another hospital, they've actually decided to talk to those pathology labs to be able to send out those tests. So everything's very streamlined, no issues at all.
So Dr. Lister, as a solo practitioner, busy, probably the only foregut surgeon in Arkansas, right?
Yes.
So how do you actually incorporate this TissueCypher into your practice?
So we actually use the portal. So when I get a Barrett's diagnosis back, either myself or my nurse practitioner will just log onto the portal and enter the patient data, and it's very quick, very easy. And then they get the order, and Castle will then contact my lab, and my lab understands the process and knows what to send Castle.
The nice thing about being an ADLT, as I mentioned, you don't need prior authorization. ADLT status provides a lot of support and assistance in having our patients being able to access this test. We don't want any financial barrier to actually prevent them from accessing this important prognosticating test. So this is the QR code. You can look it up, or you can approach any of us. This contains a link to the website to learn more about the test. And more importantly, I invite you to look to the 13 peer-reviewed studies that has been the basis for how Medicare has recognized this test as the only test and no other combination of tests that can give you this type of result. And as William Osler said, it's more important to know the patient that has the disease than the disease that's in the patient. So in line with that, TissueCypher is able to give you not just a risk class you tell a patient, you could actually get an actual score prognosing the risk of advancing to high-grade dysplasia or esophageal cancer that you could use for discussion to come up with a shared decision plan for your patient. Thank you.